Okay, we're going to start, and you either got your midterms back Monday, or you'll get them back today, or in sections later this week. So what about the points you got? And, oh, I should have got more points on that compare and contrast or essay. So here's the regrading policy. If you are really sure that you deserved 18 points and you only got 12, and the reader must have fallen asleep halfway through, you can get the exam to me, and we'll get it to whoever graded that particular part. But if you're sure that you really got screwed out of a quarter point, and you want to push the envelope, on the regrade, we might actually say, we gave you 16 points, you only deserve 14. So we're not going to just do regrades for a half point here and there. Sometimes it happens. The reader of your particular question was asleep at the wheel and you really deserve more points. But we're only going to do that selectively. So if you really feel that you deserve more points, jot a couple of sentences down on a separate piece of paper. I think I answered it this way. I only got this many points, and we'll consider it. But if it's just about a half point, don't bother, because again, you might actually get graded down on the regrade. So we had just 2 more slides left in maltreatment. Pretty heavy lecture from Monday. And we were talking about, where we left off, some of the outcomes, the multi-final outcomes for maltreatment. And it's probably an overgeneralization to say absolutely that physical abuse leads to externalizing behavior and sexual abuse internalizing behavior. With both types, you may get mixtures of aggressive and withdrawn behavior, depending on the situation. For all kinds of abuse and neglect, longer term in development, there may be depression and even despair. As a kid, I was maltreated. Maybe as an adult, I'm really not deserving of good attention from others or even myself. There are linkages between early maltreatment and substance abuse. This might be a coping mechanism to numb pain. We'll talk more about PTSD shortly, and it'll make more sense. But after particularly traumatic events, there may be post-traumatic stress reactions or post-traumatic stress disorder, which we'll talk about soon. We mentioned before, but I want to frame it in a slightly different light. One of the common but not inevitable sequelae of sexual abuse is that the child starts to act in a sexually provocative way. That's what was modeled. Maybe that's how the kid thinks it's the only way to get attention. But what happens when a kid starts to act that way? They're inviting sexual attention from older teens, from adults, and you may get a cycle of repeated sexual victimization later in life as a function of that early sexual trauma. Does abuse lead to severe antisocial behavior? It depends on the severity of the abuse. It depends on other vulnerabilities and risk factors. But very severe physical abuse may breed, in many cases, later antisocial behavior. So these are some generalizations. What if you are violated sexually one time by a stranger versus many times by a stepfather? What if you're hit once across the face versus repeatedly beaten and strapped with a belt? Obviously, the frequency, the severity of the maltreatment may have a lot to do with the outcome. Is it the abuse, or is it that you live in a family system that doesn't respect boundaries? Or in a family system that's so distant that even if they hadn't been abusive, you were going to start to act out? So a very difficult thing to do in research on this topic is, how do you separate out dysfunctional family systems more generally and the outcomes attendant to those versus the specific effects of maltreatment? Because obviously, again, you're not going to randomly assign some people to live in very dysfunctional families and a subset of them to get abused. It's all naturalistic follow-up. If you think about it differently, and if you've been a parent or you know parents, it's kind of a miracle that the prevalence of child abuse isn't 100%. Kids are hard to raise. It's nice to get sleep, and you don't sleep much during the first few years of parenthood. It's nice to have a nice, uninterrupted evening with your partner, and the kid decides to tantrum or has broken the television set as you're watching True Detective or whatever you're doing, and it's frustrating. How do you cope with consistent discipline, remember good old authoritative parenting, warmth, responsiveness, and clear limits when the kid's frustrated you, or if you've just lost your job, or if you're stressed? What's the boundary between punishment that's well-reasoned, punishment that's extreme, and abuse? It can be a fine line. We talked about this a little bit in our discussion last time. Maybe preventively, you got to pick a test to drive should you have to take a test to be a parent. What would a mandatory parenting test look like? Would it be compare and contrast and fill in the blank and essay? Would it be an interview? Would it be someone going to your home and appraising the quality of, all of a sudden, social control? Who's going to tell me I can be a parent or not? But we take it seriously with other responsibilities, like driving, and we don't have any tests for parenting. Think about designing a prevention program for physical abuse, sexual abuse, neglect. What would those parenting tests look like? I don't have any great ideas about this, but it's really provocative. Speaking of prevention, so there's an overcrowded family, and there's a lot of neglect, and there's a neglect charge brought against the family, and the kid's placed into foster care, but the parents go on to have other kids. Should there be a mandatory patch? Should we prevent abusive parents from being parents again? What's the role of social control? It's very provocative stuff, but if you're really going to talk about prevention, it's hard to just play catch-up later in the game once kids have already been maltreated. Are we out of the dark ages? Do women and children still have the full rights as to men, especially white men in society? No, I don't think so, especially with the income disparity we have. And abuse and neglect are wrapped into social and political and economic realities as well as psychological ones. How far should society go to protect kids? Are these mandatory abuse reporting laws a good thing? Or is society going too far and encroaching on the privacy of the family? Well, is the privacy of the family an excuse for maltreatment? Or should my family's decision on corporal punishment be subject to laws in society more generally? These are big issues. So on the New York Times a few years ago, these kind of things happen occasionally. A very neglected kid was placed in foster care. The foster family was obviously scamming the system, getting many foster kids in to make money, and the kid was 13 years of age and weighed 49 pounds, barely alive. This is the reality of maltreatment. I mean, this is a horror story that made headlines, but the extent of maltreatment, and again, what's officially reported is just a small proportion of the actual prevalence, may have long-term physical and psychological consequences that go beyond clearly the headlines. Question here. So, in other words, the mandatory reporting laws, has it cut down on the prevalence? Is that what you're saying? We didn't really have a baseline before. So, if anything, the mandatory reporting laws have dramatically increased the prevalence of abuse, because now it has to be reported. But of course, what you'd want to know is what's the actual true prevalence before, and do these mandated reporting laws cut down on that? But we don't have any good measure of that. So it's a very good question, and pretty much an impossible one to answer. So let me flip to the next. And who else has a question or comment? Speak up as I am plowing through. Yeah. So the foster care system would be the subject of a seminar. How good is America's foster care system? What do you have to do to be a foster parent? What about an adoptive parent? Because a lot of kids are temporarily placed in foster, and it's getting much harder to get to be an adoptive parent. What about gay versus straight parents for adoptive parents? What about cross-racial adoption and foster? Huge political and psychological issues. But there is some state-by-state screening of what an adequate foster parent is. But given the number of kids who need these placements and the number of potential foster parent families, a lot of times it falls through the cracks. Who else? Yeah, you? Like who? Yeah.
Comment is more along the lines of if they have screening and stuff for adoption and foster care, then I guess you could kind of use that as a great sort of leverage for parenting classes. But
right.
Again, if so many issues are correlated as like serious factors with SES and
yep.
all of those things, it makes it incredibly difficult to be like, well, have a kid and now I have to take classes too on top of everything else.
Oh my God, I'll never sign up for that. Yeah, exactly. And maybe the more true primary prevention would be not just screening of foster parents. What about anybody who's going to be a parent, right? So we're going to shift into internalizing problems. Remember, that's the big distinction we talked about weeks ago. If you take all of the kinds of things that a kid can do to show maladjustment, one half of the spectrum has to do with bodily concerns and sadness and anxiety and social withdrawal. The other side has to do with externalizing problems. We talked some about externalizing problems. The DSM, as it categorizes internalizing problems in kids, is a complete mess. It's a mess in many ways because categories don't really fit onto the reality we're dealing with. But for the internalizing disorders in particular, there's a lot of confusion. Maybe we should, which the director of the National Institute of Mental Health has now said is what we're going to do, and a lot of researchers are taking this up, go to an entirely dimensional system. Temperamental dimensions. One of the core temperamental dimensions in infancy is negative affect. The kids who always seem to be in a bad mood. And then you get a little bit older, and now kids are verbal, and they're expressing negative, self-deprecating thoughts all the time. And rather than say, some kids are so negative, they're anxious all the time and have a disorder, maybe we should look at the dimensions of negative affect. How inhibited are you? Does anything go, or are you pretty restrained? The DSM looks at symptoms, puts them together as syndromes, and then calls them disorders, even though there's no unifying cause. Maybe, especially for the internalizing problems, a totally dimensional view would be more accurate. And remember comorbidity, 2 or more independent disorders. Well, we'll find out that many people who are pretty anxious are also depressed. In fact, the correlation is very high. Is there really a separate anxiety disorder and a separate depressive disorder? Or should we be talking about dimensions of negative affect and low positive affect? Would that do a better job? Development is really important for internalizing symptoms and problems. If you're a 3-year-old and you're not afraid of the dark, you probably are very abnormal, right? But if you're 23 or 53, that's a problem. At what age? What's the classic sort of multiple choice question? What's the most important thing, aside from the presenting problem, a clinician needs to do at a child mental health center? How old is the kid? My kid is biting a lot. How old is he? 18 months. That's pretty good. He's got a good sense of self. Make sure he doesn't bite too hard. My kid's 18. We've got problems, right? Age has a huge impact on whether you think something is just normative or whether it's a real problem. Harmful dysfunction plays a big role here. Remember, under Wakefield's model, the thing has to be a problem. It's got to cause impairment. It's got to be harmful. But that's not enough. That's just social deviance. There's got to be a dysfunction. So what's dysfunctional about anxiety disorders, like phobias? So, oh my God, it's the heat wave now after the rains, and there's a snake from the Berkeley Hills coming right under that doorway. Or wait a minute, was that a snake or was that just a stick somebody was wiggling? It's probably a good idea if I lived on the savannas 100,000 years ago to think it was a snake. Because if it was a snake and I thought it was a stick, what happened? My genes don't get passed on, right? So what was a healthy alarm back then, now we're into an L Hall. If I think it's a snake, I've got a snake phobia. So is my underlying alarm a disorder, or is it a very healthy alarm system for 100,000 years ago, but we call it a problem now because we live in urban environments? So the question, especially for internalizing disorders, especially anxiety disorders, is there a dysfunction, or is it really kind of a healthy set of these traits you have in you, but because our culture has shifted so radically, now we call it dysfunctional? Like with ADHD, maybe it was not a bad thing for a lot of people to be kind of impulsive and on the edge before we had compulsory education. Now that we do, it's disordered. You've got to think about, especially if you're into biological psychology and genetics, are they bad genes, or were they genes that were really adaptive formerly in our evolutionary history, but they're problematic now because things have switched around so much? So think about that. Now, we're going to talk about anxiety and fear and panic. So this isn't entirely accurate, but it will help. Because recent research is now showing that there is probably different parts of your brain that are responsible for a pure fear response than for longer-term anxiety. But to help us along, let's take a different worry I have, that the Oakland Zoo, somehow the gatekeeper didn't come around and lock it, and elephants are on the loose, and they're headed for the Berkeley campus. And in fact, a bull elephant has just come into an L Hall. We better all be fearful, because if we are, we'll run like hell, right? The fight or flight response. I'm not going to fight that elephant, I'm going to flee. So that's fear. But what if now during this lecture, let's see, it's 10:27, I think I should check my phone. Maybe the Oakland Zoo has had a breakout. I'm kind of worried about it. I'm not sure I can finish this lecture because the elephants could be coming down the hill. What's that? That's anxiety. There's no real threat, but I'm hyper-vigilant to cues that maybe something bad's going to happen. So at some level, the elephant's charging in the room, I get pretty alarmed, my hormones are shifting, my skin is sweating, my GSR is high. That fear response isn't terribly different from the anxiety I get just by worrying about the elephants coming in. Now there are actually, if the elephant comes in, I get some different chemical reactions in my brain than if I'm worried about it chronically. But fear and anxiety are on a continuum. Fear is the expected alarm response if the stimulus is real, and anxiety is kind of the chronic worry that the bad thing might happen. Now what's panic? We all get anxious sometimes, whether it's before a midterm, or before you're going to ask someone out, or confront your family about something. Now imagine, it's hard to do, the most anxious you've been, and multiply that by about 100. Your heart is palpitating, you're sweating profusely, you're starting to get dizzy, and you feel like you're going to have a heart attack or you're going to faint and die. That's panic level fear. Now it turns out to have an even different neural substrate than fear and anxiety. Panic is supercharged fear, concentrated. A panic attack is a period of sometimes 5 minutes, sometimes a half an hour. It tends to sort of stop after that, sort of self-limits, in which fear and anxiety symptoms are the most you've ever experienced. What's a leading cause of referrals to emergency rooms? Panic attacks. The person thinks they're going to die. The person thinks they're having a heart attack. You're driving on the freeway and you start to have a panic attack. You pull over to the shoulder, or you get off at that exit. So, if you're prone to panic attacks, what are you going to do? My God, I was on the freeway 3 days ago, and I really felt like I was going to pass out at the wheel. I ain't going on no freeways again. I'm staying closer to home. I'm only taking surface routes. So one of the big phobias we talk about, agoraphobia, the fear of kind of being out in the open, sometimes it's also the fear of being in enclosed places, is often the result of people who are biologically prone to have panic attacks. Because if you've had one, what are you going to spend most of the rest of your days doing? Trying to avoid ever having another. So you restrict your range. I'm not driving on freeways, I'm only driving on surface streets, I'm taking a bike, I'm staying home. Because what does that do? It makes you feel like you're in control and you're not going to have that panic attack. So fear, anxiety, and panic, three big themes we're going to be talking about. Now, anxiety is kind of a complex emotion. How do we know that you're feeling anxious? Well, it depends on where we look. We could wire you up, and we could see if your palms are sweating. Last time you flew, you're not afraid of flying, it's kind of cool, and then all of a sudden you go through that thundercloud, and the plane starts to shake, and you bank really hard. If your palms don't sweat, there's something wrong, right? This is a natural response related to anxiety. Your heart rate usually goes up. You're preparing to do what? You're preparing to get the hell out of that, but you better not get out of the plane. You're preparing to get out of Dwinelle if the elephant's coming in. Dry mouth. You startle easily. Lots of hormones are circulating. So we can measure physiology as one way of appraising your anxiety. Another way is to ask you, if you would be willing to do an interview at the time, what you're thinking about. And people who are anxious are thinking about what? How to avoid the threat that's imminent. How to avoid studying for the midterm, because that'll show you how far you have to go, and so it's better not to do it at all. But you're worried about it. So worry, vigilance, it's hard to concentrate because you're worried about this anxiety attack that's going to come about are often the cognitive markers. What do you tend to do, not just think, and not just your bodily functions, how do you behave if you're in an anxious state? Well, if you're really anxious, you might, again, tremble, fidget, you're really in a kind of alarm state, but most of the time, you're going to try to get the hell out of the place that makes it so threatening. So if you have a phobia of the bridge, the Bay Bridge or the Golden Gate Bridge, related to the heights or related to being out there swaying on the bridge, but you're going to be brave. I'm going to make it. I'm past Emeryville. I'm going to do it. I'm at the toll plaza, and my God, I can make that final U-turn. So avoidance is the usual behavior in the face of anxiety. I'm not going to confront that feared stimulus. Now, what's really interesting is that when you do scientific study of emotions, and of anxiety, it's kind of a complicated emotion, it would seem logical that if you're really anxious, your body's kind of acting up, and you're thinking all these thoughts, and you're avoiding, but the actual correlation across these systems is pretty low. When does it get high? When the anxiety is really intense. When any emotion is intense, all of a sudden, you get your body and your cognition and your behavior linking up. But it's hard to know if you're kind of in a mildly emotional or anxious state. So what do? Do you believe the physiology? Do you believe what the person tells you? Or do you observe their behavior? This is one of the problems in all of psychology, especially clinical psychology, developmental psychopathology. What source of information is going to be best? Okay, let's talk about a case study. And this case study happens to be my son, Evan, who here is Calvin a couple of Halloweens ago. And there he is 2 years ago getting ready for summer camp. And there he is hiking with my wife, Kelly, and me. So this is Evan. What's Evan's developmental sequence of fears? When he was 2 and he would go to bed, he would say, I don't want to go to sleep, Daddy, the raccoons will nibble my toes. Because we live on a creek over in the other part of Berkeley here. So raccoon nibbling toes is a big fear for 2-year-olds. Now when he was 3, he was really afraid of Hussein Pingu, the sort of Swiss animated penguin who does wacky stuff. He was afraid that Pingu might visit him at night. He was really afraid of Jack Frost, because he read a book where Jack Frost would blow ice over everybody, and he was really afraid that he might have to answer the phone, because he'd say, I'm too shy to talk on the phone. So a little bit of social fear coming in. When he was 4, and we would talk with him, it's a problem of having a psychologist as a dad and an educator as a mom, we talked to him about his fears. He said, I'm not afraid of those anymore, but I don't want to go interview for kindergarten. At 6 and 7, so now he's in 1st and 2nd grade, I remember Evan saying this, that he said, Dad, the worst thing that can happen is you get embarrassed. What does it mean to be embarrassed? It means other people think you're doing bad. So now at kind of the elementary grade years, kids have reached concrete operations in a Piagetian sense, and there's a big social aspect of how am I doing? Who's got the best self-esteem in the world? 4-year-olds. And when does self-esteem start to go low? 6, 7, 8, 9, 10, because you're in the social world now. And then in a classic quote, Evan said, Dad, sometimes I'm embarrassed even when I'm alone. I think about what other people would think. So that's kind of a second order thinking about, you don't even have to be in a social situation to be embarrassed because you're imagining what it would be like if you didn't do well. So Evan's a funny kid and pretty interesting, but he shows a not too atypical progression. Animal fears, fears of the dark and going to sleep, fears of separation in the preschool years, and then some more specifically social evaluative fears, and then usually, and he's 10 now and I don't have his fears marked in the last couple of years, but often preteens are worried about death and are worried about mortality as they're approaching adolescence and getting into formal operations. Thank you, Evan, for giving permission to be the subject of Psych 131. So, what does the DSM say about this? They're trying to classify anxiety disorders in a way that makes some sense. So the most common anxiety disorder in kids, and the earliest developing, is separation anxiety. Well, what do you do in a strange situation? You try to induce separation anxiety, experimentally, right? The infant's in there with mom or dad, and then mom or dad leaves, and then the stranger comes in, and you're trying to induce this state of a little bit of abandonment to see how the kid reacts, especially upon the reunion. But what if, and this is hard, you're the parent of a 3-year-old, you're trying to go on a date with your partner, and the kid says, don't leave, I won't stay with the sitter, and starts to tantrum. That's separation anxiety. But what if the kid refuses to go to kindergarten and almost has a panic attack when you put him or her inside the kindergarten door? Now you start to think about separation anxiety.